Well, good morning and welcome to Grand Rounds here at Virginia Mason Medical Center. My name is Amish Dave and I'm your Director of Continuing Medical Education here at Virginia Mason. It is my pleasure to welcome as our Grand Rounds speaker this morning, just kind of one of the warmest, friendliest people that you can possibly speak with, Dr. Astrid Pujari. Dr. Pujari is going to be speaking to us more about sugars and updates on integrative medicine this morning. But a little bit more about her. She completed her medical school training at Tufts University School of Medicine in Boston, followed by residency at Scripps Clinic and Research Institute in La Jolla, California, and then completed further training at the College of Phytotherapy in East Sussex, England. She is double board certified in internal medicine and integrative medicine and sees a lot of our patients both in person and virtually through telemedicine. We're just so glad to have her speak today on natural support for blood sugar. Welcome, Dr. Pujari.
Thank you so much. It's really nice to be here. Thank you for coming. And so, we're going to talk today about natural support for blood sugar and what the evidence is. So, I just want to start by saying that today the talk is going to really focus on normal or prediabetes rather than as much focus on type 2 diabetes. We'll have a little bit of discussion of that, but not a huge focus. And then type 1 diabetes, we're not going to be discussing because that's really in a different category. So, this is just a reminder for all of us. I know we know this, but I'm just putting up here to remind us that what the criteria are for normal, for diabetes, in terms of fasting glucose, hemoglobin A1C, and the oral glucose tolerance test. And then we just as again, as a reminder, there's this in between zone of prediabetes where you have about a 5 to 10% risk of developing diabetes every year as a person. If you have prediabetes, that's the issue there with prediabetes, and probably why that category was created. I want to start before we jump into the slides on blood sugar. I just want to talk about this question, which is our evidence really evidence? And this becomes particularly relevant with diabetes. So, this is why I wanted to spend a few moments talking about it first. So, this is some writing from Marcia Angel, who was the executive director, physician and executive director of the New England Journal of Medicine from 1988 to the year 2000, so almost 2 decades. She was the executive director. And here's what she writes. And she's written extensively, actually, since being the executive director on this topic. She's written quite a bit, so you're welcome to check that out if you wish. But basically, here's some summary points that she mentions. Conflicts of interest exist in virtually every field of medicine, particularly drugs or devices. It is simply no longer possible to believe much of the clinical research that is published or to rely on the judgment of trusted physicians or authoritative medical guidelines. I take no pleasure in this conclusion, which I reached slowly and reluctantly over my 2 decades as editor of the New England Journal. The User Fee Act put the FDA on the payroll of the industry it regulates. Last year, the fees came to about $300 million, which the companies recoup many times over by getting their drugs to market faster. So she wrote this. Actually, this particular piece of writing is from 2007. So the FDA amount, the $300 million she's discussing there, is actually 2006. So let's look at where we're at now with that act. So this Prescription Drug User Fee Act she's discussing was actually instituted in 1992. And in 2024, the application fees, so if a pharmaceutical company basically wants to put a new drug on the market and then they have data that they want to submit with that application, they have to pay $3.5 million for just the application. Then the annual program fee to basically keep that drug on the market. Every year they've got to pay this program fee for every single drug they have on the market. They're paying this program fee. That's $400,000 per drug per year. And then the impact is that in 2022, these fees were 45% of the FDA's budget and can exceed $1 billion annually as of right, currently. And so what they found in these studies that I cite below is that the time to approve new drugs has decreased since this act was passed. In addition, as you can see in this New England Journal, drugs approved under this timeline, because this act actually has a timeline to it, are more likely to have safety issues or receive a black box warning after approval. And then, as you can see in this other study, there's basically a rush to approve new drugs with incomplete data or concerns raised by advisors in order to meet this timeline. So then the FDA in general has been shown to have conflicts of interest. So in JAMA, what they found in this study was that the FDA advisory committee, so there's a committee that reviews drugs, and so that committee often has financial ties to the pharmaceutical industry. So you can see in this particular study, they found 1/3 of the experts on this FDA, review committee had financial conflicts of interest with the drug companies. And the Public Citizen, this is a not-for-profit sort of advocating, in 2012 found that the FDA is too closely aligned with the pharmaceutical industry. In addition, the FDA in research has been described as what's called a revolving door. I didn't come up with this name, but so FDA officials, basically the idea here is that FDA officials will often have previously worked for the pharmaceutical industry, and then after their job at the FDA, then they'll take a job with the pharmaceutical industry. So for example, just as an example, there was an FDA commissioner in 2017 to 2019, and he was on the board of several pharmaceutical companies prior to the FDA, appointment as commissioner. And then after his FDA position, he actually went to work for Pfizer. So this is what they mean by that. So the question then becomes, well, when is evidence really evidence? And here's some studies around this point, which is part of why we do disclosures for financial ties and so on. But honestly, that's kind of a drop in the bucket. So industry-funded studies are more likely to find pro-industry conclusions for the drug. Pharmaceutical companies often publish only the most favorable results. There's often publication bias to those, results. In JAMA of 2008, they found pharmaceutical companies often hire professional writers to draft and edit the articles that are then attributed to the academic researcher in question. So there's obviously then a question of bias and safety and efficacy. And then this Cochrane systematic review found that industry-sponsored studies, they often overestimate the benefit of a drug and underestimate the risk. So medical guidelines also have issues, unfortunately. So they have been found to be highly influenced by pharmaceutical funding. So what we see in this article in JAMA Internal Medicine in 2013 is that clinical guidelines often have authors with financial ties to the pharmaceutical companies. So for example, this report, by the way, the Patients for Affordable Drugs report, is very, very thorough. So if you're interested in this topic, I highly recommend you take a look at it. They're a not-for-profit that did a pretty thorough analysis in 2021. And I couldn't list all of the different organizations. There's an enormous list here. I just took the two that I thought were most relevant for today's talk. So the American Diabetes Association and the American Heart Associations are the two that I highlighted here. So you can see that they have categories. So the categories are, so basically, let's look at the American Diabetes Association as an example. Accepts funding from pharma industry, fails to fully disclose pharmaceutical contributions, has board members with financial ties to the pharmaceutical industry, shares lobbyist and/or lobby firm with the pharmaceutical industry, and failed to support Medicare negotiation for lower list prices in 2021. And I put the reference there in case you want to take a look at that report yourself. So then what I did is I actually went to, because these organizations now have to disclose where, they're sort of contributors. So I actually just pulled the report from 2023 and I put part of it on here. Honestly, I couldn't even fit all the national supporters that were between 150 to 499,000 here. So, but you can see the $1 million plus donors here. Then there's donors that are $500 to $999,000. Then we have donors that are $150,000 to $499,000, and that list, the 150 to 499,000. That one I couldn't list all of it on the slide. So, but basically the point here is you can see that a tremendous number of these contributors are actually device companies and pharmaceutical companies, as well as interestingly pharmacies. So, so just noticing the amount of investment here from these companies. This is another point now, going back to Marcia Angel, who really, from her work with New England Journal, started to notice this and really start to talk about it in a very public way. She writes here, drug manufacturers prefer to work with academic medical centers because it actually increases the chance of getting research published and provides drug companies with access to highly influential faculty physicians. Increasingly, the industry is setting the research agenda in these academic medical centers, which has more to do with the industry's mission than with the academic medical center's mission. And researchers and their institutions, she states, are focusing too much on drug development, not enough on prevention of disease. So is that true? Well, let's look at this. So again, I pulled another report here. This is actually a report from describing U.S. investments in medical and health research between the years of 2016 to 2020. So we're just looking at data here on how much money is going into research and what it's from. So we can see that 2/3 of the medical and health research is basically sponsored by the industry. So we can see this is in millions, this report. And so you can see the top line here, industry funds most of the research. So we're getting, it says 161,766, but that's actually in millions. And that's the share of total investment. So they're sponsoring 66% of research. If we include academic and research institutions as part of that, because as Marcia Angel just described, there is a link there between academic institutions and the industry, then we would bump it then to 75% of our research is basically being funded by the industry, approximately. And this was in the year 2020. Here's another table from this same report that goes through it from 2016 to 2020. So let's look at this. This is more of a report on, well, what are we spending our money on? So once we have this money, what do we spend our research money on? And we can see that basically 88 to 92% of what we spend our research money on is basically on pharmaceuticals or medical technology, with very, very little on healthcare services or on lifestyle. So this is highly, highly relevant for today. This is the question. So how is this all relevant to today? Well, it's very, very relevant to diabetes and prediabetes, because we all know that lifestyle research lifestyle is the greatest influence on long-term health and costs with diabetes. And there's quite a bit of data about this, but the point here is that lifestyle research is highly underfunded compared to drug research, is my point. But the problem is that with diabetes and with many chronic diseases now that we're seeing, so, I went into what I do now is being the head of the medical director for the Center for Integrative Medicine here, because I believe that lifestyle actually is something we can do to change really our population's health before we need pharmaceuticals. And the data shows that the greatest influence on long-term health and cost for diabetes, but for heart disease and other things, is actually prevention. Once we've gotten to diabetes, it's too late. Often. I'm not saying it's really too late. You can still do things to, help with that. So maybe I misspoke there. What I'm saying, though, is that if we can prevent, we're really going to change outcomes for many, many people. And so lifestyle has shown the greatest impact on prevention. It has the least side effects, and it's very cost effective. In even 15-year analysis, I wrote 10-year analysis here, and we'll go into this studies in a minute. So let's actually look at probably the best known study. I still remember when I was a primary care doctor when this study came out and how much it influenced our practice. Actually, it was basically a landmark study. So we're going to spend some time going through this study because it really changed practice of primary care a lot. So basically what they found was in this New England Journal, and it was a little more than 3,000 patients, they basically took a group of people with prediabetes and they said, okay, we're going to compare lifestyle metformin to placebo over 2 years. And what they found was that with lifestyle, there's a 58% reduction in the development of type 2 diabetes mellitus over 2 years, which is remarkable, absolutely remarkable. And they've continued that information now. They've done reanalysis. 10 years later, it was 34% reduction. And they've even followed these patients out to 15 years now, which they still continue to see a reduction in the development of type 2 diabetes. And what they saw in addition, you'll notice, is that there's a lowering and better control of cardiac risk factors, sustained weight loss, and it's very cost effective. So we're not only influencing diabetes here, we're also influencing heart disease, which we know is one of the top causes of death in the US. So what the authors in the 10-year analysis, this is a quote direct from them, the 10-year within trial intention to treat analysis of the diabetes prevention program demonstrates that lifestyle is indeed cost effective. When a treatment is more effective and less costly than usual care, it should be widely adopted and used. However, what they point out here is that fewer than 1 in 5 new interventions, and keep in mind, most new interventions are basically pharmaceutical drugs. So fewer than 1 in 5 new interventions in medicine are actually cost saving compared with usual care. Lifestyle is cost saving. So let's look now, again, as Dr. Dave kindly mentioned, so I did primary care actually here at Virginia Mason, and in the past, and what we usually say is to do the Mediterranean diet we recommend that a lot. So the Mediterranean diet, and we also recommend 150 minutes of exercise per week. And that's for many things. And that's a great recommendation. It's actually based on this study. So that's where we came up with that handout and that recommendation. But what I want to point out now for a moment is the amount of counseling and support these patients got. So you can see they got individual coaching weekly for 16 weeks in this study. They got group visits weekly for 16 weeks. And then in both of those, for both the individual coaching and for group visits, then they moved to twice a month, and then they moved to once a month. So this is a lot of coaching. And that is my experience doing what I do, because basically I'm working with people on behavioral change all day long. That's literally what I do now for a job. And what I've noticed clinically, and is sort of panned out in this study, is that behavioral change requires a lot of time and support. It's not a quick thing. People need, and we all need as people, we need encouragement, we need accountability, and we need support doing that. And it doesn't all have to come from the actual provider. I am a provider who does that, but there's other ways to do it as well in addition. And the point here is that even with all that, it was cost saving over the long term. So even with all that support, it was cost saving. In primary care, we often do a handout, like we give people a handout, eat this diet, do this amount of exercise, or we'll do a periodic recommendation because we're not seeing people all the time, right? We have very full practices. So we might see them once every 3 months, once every 6 months, and we might remind them. But that's really very little. And it's honestly, primary care is very full. It's a lot that people have to do. And already doing that is asking a lot, honestly. That being said, the point here is that patients need a lot more support to actually achieve the change that we want them to empower them to do. And actually, the National Clinical Care Commission, which was a commission that was started in 2017, it actually in order to address this fact that we have quadrupling rates of diabetes over the past 30 years in the United States, so they created a commission only to address diabetes, and they created a report to the US Congress in 2022. And their recommendation, you'll see here, is that they recommend federal programs to address prevention, because their point is that the current model of pharmaceutically based recommendations is not working for our population. We're intervening too late. And a lot of these are determined by many different aspects of lifestyle, social determinants, health, things like that, that basically what's been said in research is we're paying lip service to lifestyle, but we're really not helping people to actually achieve it because it needs a lot of support. So, and then this also highly affects marginalized communities, but it also affects all of us. It's everybody, and highly affects marginalized communities. So the point of all this is that medical practice has become highly pharmaceutically oriented, which may be in part due to the discrepancies in our priorities and research funding. This is affecting the health of our population, including with diabetes, probably with other things like heart disease, which is highly affected by lifestyle and often can be prevented by lifestyle. So now the question, okay, so now we've talked about the diabetes prevention program, and they took a group of people with prediabetes and prevented diabetes, right? But let's look, the question then becomes, well, should we be intervening even earlier, okay, before we even get to prediabetes? So this is the question of, well, is normal blood sugar really normal? Well, it turns out probably not, shockingly. So New England Journal in 2005 took a group of 74,000 men, a little more than 74,000 men in the military, and they followed them over more than a decade. And what they found is there's a progressive increase in diabetes with any fasting blood sugar above 87. 87 is, we consider perfectly normal, right? Remember that our criteria for prediabetes is 100 or above for fasting blood sugar. So this is a fasting blood sugar of 87. We have a progressive risk of diabetes. In addition, what they saw is a fasting blood sugar in the 90s, basically, with a slightly elevated triglyceride, your hazard ratio of diabetes goes up by 8.23. In addition, this large study of 46,000 patients of Kaiser, again, this was a 10-year study, so they followed patients for 10 years. And they placed people into different categories depending on their fasting blood sugar. For every 1 milligram per deciliter increase in fasting glucose above 85, you upped your risk of diabetes by 6%. So, for example, in the 90 to 94 range, you're 49% more likely to develop diabetes. In the 95 to 99 range, you're 2.33 times more likely to develop diabetes. So what we're considering to be normal blood sugar may actually not be normal. We really, these studies suggest that 85 to 87, anything above that, we're starting to increase our risk of diabetes. In addition, this other point is around heart disease, because we know that sugar and heart disease are very, very related. In fact, sugar and cancer are also related. So we know with diabetes, for example, there's an increased risk of breast cancer, endometrial cancer, colon cancer, liver cancer, pancreatic cancer. Some of that may be because with those higher blood sugars, you're getting more oxidative stress in the cells, and then the insulin actually can act as a growth factor. But going back to heart disease, what we see here is that, again, remember that our hemoglobin A1C cutoff for prediabetes is 5.7, okay? So in this study of more than 10,000 patients over approximately, again, a decade, what they saw is a continuous significant increase in cardiovascular disease and mortality for any hemoglobin A1C above 5%. So prediabetes is, again, 5.7. So anything above 5, though, we're starting to see an increase in heart disease. And for every 1% increase above 5, we're getting an increased relative risk of death of any cause. So for men, it's 1.26, and for women, it's 1.28. And that's independent, by the way, of any other risk factors. So our traditional risk factors, age, tobacco, blood pressure, et cetera. This is another study, and I just wanted to show you a graph so you could see the curve here. So this is a study from the Archives of Internal Medicine in 2005. What we're seeing is that This was even stricter. So actually above any hemoglobin C above 4.6, for every 1% increase, you're seeing a relative risk of heart disease of 2.36. So you can see this curve is quite steep here. So anything above this right here, this area here is 4.6, and we can see it really increases quite a bit. Actually, with diabetes, there is an increased risk of heart disease, but actually the line is more flat. It's not quite as steep. So with these blood sugars, though, we're seeing a steeper rise in heart disease for anything above 4.6. Okay, then we go back to what's called the oral glucose tolerance test. We don't, at least in the US in my experience, we don't do these tests as frequently anymore, but maybe we should be. And this is based on the DECODE study. Actually, the DECODE study is what influenced the World Health Organization to keep the oral glucose tolerance tests as one of their tests for diabetes. So because they were debating whether or not they should keep the oral glucose tolerance test or just go to fasting blood sugars, hemoglobin A1C. But they decided to keep it based on this study. So this was a large study of 29,000 Europeans comparing the oral glucose tolerance test to fasting glucose for diagnosis. And what they found, interestingly, is that with the oral glucose tolerance test, they were able to do everything you could with a fasting glucose. But the 2-hour glucose tolerance test results actually gave additional information that fasting glucose didn't give. And that additional information was if people had a glucose on the oral glucose tolerance test that was above 200, they had a 100% higher risk of all-cause mortality and a 50% higher risk for heart disease mortality. And this was even with a normal fasting glucose. So I'm going to repeat that. Even with a normal fasting glucose, if the 2-hour glucose was above 200, it ups the risk of all-cause mortality by 100%, 50% up in heart disease risk. Because of this, the World Health Organization kept the oral glucose tolerance test as one of its tests. But we'll go into this, but this might be why we also need to pay attention to postprandial glucoses. So what our glucoses are doing, even if we have a normal fasting glucose that we're seeing, we may need to be paying attention to the glucose that's happening 2 hours after we eat. And so basically the 2-hour oral glucose tolerance test was a better predictor of cardiovascular events than fasting glucose alone. I should back up and say the oral glucose tolerance test is a little bit of an artificial test in a way because you're giving liquid, like you're giving a glucose load of 75 grams and then you're checking blood sugar afterwards. So it's a little bit, it's not necessarily what we'd always do in real life, although maybe with a big gulp you might. I don't know. I haven't checked that. Maybe I should. Probably will after this talk. Okay, so anyway, moving on. So the summary points here of what we've just discussed are above a fasting blood sugar of 87, the risk of developing diabetes increases progressively, okay? And above a hemoglobin A1C of 5%, the risk of heart disease increases progressively. And these are both normals. And a blood sugar above 200 postprandially, meaning if your blood sugar is 200 after meals, even if you have a normal fasting blood sugar, you may have increased risk for heart disease and mortality. So, so what actions can we take? Because I like to remind myself that I'm a patient too. So one is not to take diet for granted. It's a really important point. If there's one thing you can walk away with, hopefully, it's please do not take your diet for granted. So the standard American diet is high caloric density, but nutritionally very, very poor. So let's go through that in a little bit. So you can see here that 63% of what the average American eats every day is processed food. And I could analyze this till the cows come home, but there's a lot of issues with that. And to begin with, for this talk, the glycemic index, meaning your postprandial glucose will just often skyrocket after processed food. Okay, so then in addition, we see that 25% of it is animal food. So we're getting animal food and processed food for most of the diet. Only 12% is plants, and I will point out that in this graph, even though it says plants, potato chips, French fries, and ketchup all count as plant food, even though they're not high quality. Okay, so that's important to keep in mind. In addition, this is a graph of our sugar consumption in the United States over the past few hundred years. We can see in the 1800s, we were eating 10 pounds of sugar per person per year. Now, and it's probably higher now, but anyway, as of the year 2000, we're eating 110 pounds of sugar per person per year approximately. So that's a pretty big difference in sugar consumption. And the title of this talk is, or this article is by 2606, the U.S. diet will be 100% sugar. Hopefully not, though. Okay, so anyway, so then going to the National Health and Nutrition Survey. This is a really big survey that the U.S. government does periodically itself. So the government does it to actually survey how are we eating as Americans. And so the last survey was done between 2007 and 2010. And so let's look at what they found. So in the NHANES data, and this is all publicly available information because it's put out by the U.S. government. So what we see is that 100% of the population is not meeting requirements for potassium. These are just minimum basic requirements, not even going above the standard recommendations. And then we can see the high number of deficiencies of vitamins in the standard American diet. So choline, for example, which is 92% deficient in most of the population, is now considered to be an essential B vitamin because it's been associated with fetal neurotube defects, like folic acid. So, anyway. And then excess sodium is in 97% of the population. And fiber is much too low, so we're at 16 grams. The goal is around 35 grams, depending on whether you're a man or a woman. So we're quite low in our vitamins. I know this is a busy slide, but I just want to walk through this a little bit with you. So you can see here, this is what, if people were just eating and we didn't fortify our food, these are what where we'd be at. So you can see, okay, let's just use something simple like folic acid. Okay, we know that folic acid, this is very well known in Western medicine, so we'll just stick with that. Where's my cursor? So here, people are on average, if the food wasn't fortified, they would be getting 159 micrograms per day. This is a risk for fetal neurotube defects, okay? This level of folic acid, not to mention a lot of other problems. The basic RDA is 400. And you can see that then because we fortify our food, meaning what happens is the U.S. government requires us to put folic acid in some of our foods like pastas, etc. If that wasn't required, we would be grossly deficient and probably have a lot more problems in this country. So we're barely making it above the RDA here by adding a multivitamin effectively to our food. And this goes on. Every single nutrient that I've put in yellow here, this happens, okay? So we add iron to our food. We can go on and on. Look at vitamin C, for example. Our US RDA is 75, 66. We'd probably be seeing more people, vitamin C deficient. And we understand that that's related to scurvy, or at least increases risk of scurvy, right? So if we weren't fortifying our food, so when we see studies that say don't use a multivitamin, in fact, we're using a multivitamin. We're just sticking it in our food, and it's not even good quality multivitamin. So I just want to point that out, because without that, our population would actually be worse off than it is now. So it's very important to pay attention to diet and to realize that what we're eating as Americans is not necessarily our best choices, okay? So we know from the Diabetes Prevention Program and study that the importance of weight loss and exercise. I mean, everybody knows that for prevention of diabetes. And we're also often taught in Western medicine about the importance of portion size. So I'm not going to spend a lot of time on portion size. We know that that's important. We want our portion size to be appropriate. So that's about quantity. What I want to point out today, just because this may be a little bit different, is also to think about quality. And you may already know this, but I just want to point out some of the data around it. Whole foods, when they're instead of processed foods. Whole foods have a 20% lower, if you have whole foods, 20% lower risk of death from all causes. Processed foods, refined carbohydrates, increase chronic disease and mortality independent of calories. And how is that? Because whole foods are more nutrient dense, they have better fat quality, they have a lower glycemic index. So remember, a glycemic index is how fast your blood sugar spikes after eating, okay? So whole foods will do that less. So again, this is a busy slide, but what I wanted to do here, and this is honestly a very brief overview because diet we could spend 2 days discussing, but these are the main diets that patients are currently using for weight loss, okay? So I just want to review some of the data with how it's relevant to today's talk. We've discussed that the Mediterranean diet is what they use in the diabetes prevention program. You'll notice that they use in the Mediterranean diet a lot of whole foods, which is actually excellent. The Mediterranean diet helps with weight loss because it's going to be lower caloric density than most processed foods, and it develops healthy eating habits, which is really, really great. In terms of, now again, very brief overview of, please, there's many studies on each one of these, so I can't fit all of that here, but I just highlighted some of the key points. We see in the PREDIMED study in 2013, the Mediterranean diet drops the risk of heart attacks and strokes by 30%. As we've already discussed in the diabetes prevention program, it drops the development of diabetes by 58%. There's a lot of studies that are based on what are called the MIND diet, and the MIND diet's basically Mediterranean plus DASH. So you may know about DASH as a lowering of hypertension, but when they combine those two, what's fascinating is it lowers the Alzheimer's risk by 53%. It helps with prevention. If it's followed strictly, it helps with prevention 53% if followed strictly, 35% if followed moderately. And even if somebody has a genetic marker for Alzheimer's, so ApoE4, ApoE3 still helps lower risk. The EPIC study is one of the largest, so that's written here. Trying to get the cursor. One of the largest cohort studies in the world. So this was for 2 decades. And they were looking at both Mediterranean and plant-based diets. And basically what they saw is that both of these diets lower cancer risk, they lower heart disease risk, they lower stroke risk, and they lower diabetes risk. So basically, this is why in medicine so often we recommend the Mediterranean diet. It's widely regarded as highly sustainable, easy to adopt, high variety. And the thing about the weight loss with Mediterranean, though, is that it'll be more gradual in general because you're eating lower caloric density, but it takes time to do. Low-carb diets, a lot of people that I see like or do these diets, and basically they're cutting the carbs. It depends on what the diet is, specifically keto, paleo, etc., or variants of those, but you're basically decreasing the amount of carbohydrate intake. Whether it's whole foods or not depends on the patient and on the counseling that they get. So I see some patients, they're really not choosing great choices for low carb, and some people are. The idea here is that in doing that lower carb, you're using fat for fuel more than carbohydrate, but it kind of depends on the diet. What you'll see here in the studies is that there's actually some interest here on using it for diabetes. So in this 2018 study, you can see the hemoglobin A1C drop with this study was 0.5 to 1%, which is similar to some medications actually. In this study in 2018, this was a 1-year study, a 40% decrease. So 40% of the people were able to drop medications for diabetes with doing this study or with this diet. In 2019 study here, 53% of people were able to drop medications for diabetes. And in this Lancet study, 2018, they lost weight, their insulin sensitivity improved. And here in this study in 2020, they actually took patients on insulin, and they saw a 60% drop in insulin use over 10 weeks. So this type of diet may be interesting for people who actually have diabetes to help decrease medication use. The issue, though, is, and it does cause rapid short-term weight loss, especially in the first 6 months. The issue is the sustainability long-term. That really hasn't been studied yet. And clinically, I'll say some people can do it long-term and some people can't. Really, in my experience so far, it depends on the person. Quality of the food really depends on their counseling and what their choices are. With some of them, you can actually get some nutrient deficiencies. So I listed those here. Intermittent fasting, I did a whole Grand Rounds talk on, so I just wanted to mention it because it's very popular with patients, but you're welcome to look at that Grand Rounds to get all the data on that I could find at that time. And then the plant-based diet, that's more vegan or vegetarian. It's another way that people do to lose weight. You'll notice here that, again, a lot of these plant-based diets are usually whole foods based, depends on the person. You do develop healthy eating habits and you lose weight because it's lower caloric density. Now, the studies here, again, what we're seeing is lower cancer rates, lower heart disease, lower stroke, lower diabetes. In this study, again, the hemoglobin A1C drop was around 1%, which again is similar to medications. You get some weight loss. Probably this diet is most famous because of something called the Lifestyle Heart Study. And that Lifestyle Heart Study, actually, there's a number of different publications around that. But basically what they looked at is a very low-fat vegetarian diet. And they saw, you can see here, they took people who were actually scheduled for bypass surgery, who actually had angina, and they had a 91% drop in their angina rates versus 165 increase in the control group. And also there was actually reversal of atherosclerosis by 28%. And I believe that was on cardiac catheterization versus an increase of 7.9, or forgive me, I think that might be different. 28% increase of heart disease, atherosclerosis, and then 79% better with doing this diet. So the point here is that lifestyle heart diet, there's some data around that, around helping to reverse established coronary artery disease and helping prevent surgery potentially. Okay, so the point, going back to the overall point, is that 7 out of 10 adult tests could be prevented through lifestyle changes. And the point that they're making here in this study is skilled lifestyle modification practitioners are an important yet woefully underutilized resource. Each year, 75% of Americans attempt to adopt a new health practice, yet just 16% of these efforts are reported to be very successful. So this is what we're saying about coaching, etc. So this is some studies on coaching and group support. We can see that regular contact with a coach helps weight be more successful and healthy eating habits be more successful. It also helps with overcoming emotional eating, which can be a big part of weight gain. And as we know from the diabetes prevention program, going back to that landmark study again, coaching and group visits were key in allowing that to be successful as it was. So the point here again is that behavioral change requires frequent individualized contact, and more touch points are better. So if you have a dietitian, a provider like yourselves, coach, group, app, the more the better, because it encourages support and accountability. And I will add now a pitch for integrative medicine. This 2010 National Health Survey data of 23,000 people found that people who use integrative medicine are 64% more likely to rate their health as improved over the past year, because we do specialize in helping people to achieve behavioral modification. So other tips on blood sugar, what else can we do besides the diet pieces that we mentioned? So one is having a bigger breakfast and a lighter dinner. So let's go through why that is. A couple of these slides now, I actually also discussed in the intermittent fasting talk. So you may or may not recognize them, but just to review. So in 2018, they took a group of men with prediabetes. They supervised every single meal they had, which is kind of amazing for 5 weeks. Sounds kind of intense to me. And they had an equal number of calories. So they had the exact same meals 3 times a day. The only difference was when they timed it. So, forgive me, if they had more of their calories between 8 to 2, they had a much bigger drop in their mean insulin levels. They had a drop in blood pressure. You can see it's almost equivalent to medications here at 11 systolic over 10 diastolic. They had an improvement in their oxidative stress, because when we get these high blood sugars, it stresses our mitochondria and ups oxidative stress. That's actually probably one of the mechanisms by which those high sugar levels then correlate to increased rates of cancer and diabetes, right? And decreased appetite in the evening. So basically, putting more of your calories earlier in the day helps to change your insulin response. So here's another study to that point. So this is a study of women who had obesity with metabolic syndrome. And again, they had the exact same number of calories, 1,400 kilocalories for 12 weeks. The only difference is when they consumed half those calories. So in this study, if half of their calories was consumed for breakfast, you can see that they had waist circumference loss, which measures visceral fat, 2.5 times more if they had it for breakfast. And their triglycerides dropped 33%, and the area under the curve of insulin dropped 25%. So just putting more of your calories for breakfast helps your insulin response. And interestingly, this is also relevant for type 2 diabetes. So we see this same phenomenon with type 2 diabetes. If they have a higher energy breakfast versus dinner, their overall postprandial hyperglycemia over the entire day is improved. Okay, another thing we know very well from type 2 diabetes, but I want to talk about it with normal and pre-diabetic populations too, is soluble fiber. Okay, so examples of soluble fiber, because sometimes, so just as a review, soluble fibers is basically, if you think about soluble fiber, it's like oatmeal. It turns into gel when you put it in water. Versus if you take wheat bran and stick it in water, it's going to turn into sawdust, right? It just floats on the water. So soluble fiber is anything that basically forms like a gel. And that, so examples of that are chia, ground flaxseed, psyllium, and oatmeal. There's not that many grains that are actually high in soluble fiber, but oats and barley are. So those are examples of soluble fiber because they're going to get a little bit gluey, okay? So this is in a so-called healthy population. They don't have metabolic disorder. But what we're seeing is with having some sort of soluble fiber, so beta-glucan is basically the type of soluble fiber in oats. Psyllium, like I just mentioned, is actually another type of soluble fiber. So you can see you get a 20 to 25% reduction in your postprandial glucose if you have soluble fiber with your meals. Now, what I would like to say too is, as a reminder, going back to that earlier slide, remember with that study that showed with the oral glucose tolerance test, if your blood sugar is above 200, but you have a normal fasting glucose, it's important to try to lower your spike at that 2-hour mark based on that study. So doing this, that's sort of the relevance here for a normal population, is it'll help that glucose sort of be flatter. Okay, so and then in a pre-diabetic population, we're seeing also that having soluble fiber drops your glucose postprandially by 14 to 20%. Okay, and that's also, by the way, these recommendations are also standard for type 2 diabetes mellitus. So we know that soluble fiber also helps with that. But that I just want to point out for normal and pre-diabetic populations. Walking 10 to 20 minutes after meals, especially within 15 minutes, has also been shown to lower postprandial glucose. So here's some studies on this. This dog is not walking, but running. So he looks very enthusiastic about it. So I thought he could pep us up in our enthusiasm for walking. So what we find here is that with pre-diabetes, if you walk 15 minutes after meals, especially after dinner, because if you eat more of your calories at dinner, there's a bigger insulin response. So what I was taught in med school is a calorie is a calorie, doesn't matter, if you get calories in, calories out, that's what determines weight. That's what I was taught. As it turns out, that's not true. If you have a calorie at dinner, it's actually more insulin, you get more of an insulin response than if you have it for breakfast. The other piece is that if you walk after meals, you drop your postprandial glucose by 12 to 22% if somebody has prediabetes. And if you're so-called normal healthy population and you have a high carb meal, you also drop it 15 to 20%. Now, I want to point out, even if people can't walk after meals, exercise at any time still helps glucose. Okay, so this is not to say that you can only do it this way. there are plenty of studies showing that exercise at any time helps with glucose, and it'll help throughout the day. This is just in addition, some additional information around postprandial glucose specifically. Okay, so after eating. Avoiding sweetened beverages. This is honestly a big topic in the United States. And so what we can see here is that between 1997 to 2001, our consumption of sweetened beverages has increased 135%. Most of that is from soda, things that people call drinks. If it has the word drink on it, it can be, there's a whole host of different things it can be. It's not necessarily natural. Fruit juice, lattes, all of those things. I know in Seattle we love our coffee. All sweetened beverages basically are being discussed here. The biggest source of added sugar to the diet in the United States is from sweetened drinks. Okay, so 80% of our added sugar between 1962 and the year 2000 in this study was found to be from sweetened drinks. So this is highly relevant. Okay, now the problem with sweetened drinks is they don't satiate us as humans in general. Okay, so I'm not speaking of a particular person, but in general they don't. Why? Because they don't trigger our satiation hormones. So ghrelin, leptin, all of those, they don't get triggered in the same way. So what ends up happening when we have a sweetened drink in general, okay, is that because the body doesn't register that they've had these calories, in effect, what we're doing is we're adding about 100 to 300 calories per day extra that aren't getting registered by our body. Okay, so if we eat it as solid, our body will register more easily that we're satiated and will register it as calories. If it's as a sweetened drink, it's much harder for the body to register. Again, this might not apply to a specific person, but in general, that's the case. Okay, so this is why then, if we have people who are then eating an extra 100 to 300 calories in the form of sweetened drinks per day, it makes sense that over a year, people are going to gain weight. Okay, so here's some of those studies. For each serving of sweetened beverages in children, we have an increase of obesity of 60%. And we know that rising obesity rates among children is a concern right now in the United States. They've actually, and I didn't put this study in here, but they've done studies showing that if we just taxed, there's actually an article where one author is recommending taxing sweetened drinks to help to, to help to decrease this. But Nurses' Health study of approximately 91,000 patients showed that if people drink one soda a day, it increases your risk of diabetes by 82% over 4 years. 2 sodas a day increases the rate ratio of type 2 diabetes mellitus by 1.24 in African American women. Sweetened beverages have been correlated to weight gain in a review of 30 studies in 2004. And artificial sweeteners, so I get a lot of questions from patients about artificial sweeteners. They really are no better. So the reason is because with the sweet taste on the tongue, you get a trigger of insulin. And then what happens is we don't get the actual calories to register, oh, the insulin, it's like our body doesn't register that it got sweet. So because of that, the insulin hangs around and then increases fat storage on the body. Okay, so that's why artificial sweeteners have actually been, interestingly, many of them associated with more weight gain than even actually having sugar. And the other problem with artificial sweeteners is they're extremely sweet. So they alter the perception of sweet taste on the tongue, and then people crave more sugar to try to mimic that. So in any case, in the Framingham Heart Study, which we're all very familiar with because of the power of that study for heart disease, but one or more diet sodas increase the risk of metabolic syndrome by 36% and increase type 2 diabetes mellitus by 67%. Okay, so in summary then, for this talk, what we've talked about is there's a high conflict of interest influencing medical practice on many levels, so including the FDA, scientific publications, medical guidelines, and organizations. And it's not just advertising on TV. I had one doctor say, isn't it just advertising on TV? It's not, actually, as it turns out. Lifestyle changes are very important. They have a high impact on diabetes, they have a high impact on obesity, they have a high impact on heart disease. They are cost effective but underemphasized and underfunded compared to drug management practices. And patients do need a lot of support to change, but currently most of the funding is going towards medication, and that's just our practice model right now. Normal blood sugar may not be normal. So, as I've shared, there's a linear increase in heart disease risk and diabetes risk, but there's a linear increase of heart disease risk with any hemoglobin A1C above 5. The 2-hour oral glucose tolerance test above 200 suggests that even with a normal fasting blood sugar, we may have a pretty high risk of mortality and heart disease. And then these are suggestions here. So focusing more on whole foods, eating more earlier in the day, increasing our soluble fiber. And that soluble fiber can help both with prediabetes and normal people, normal meaning non-diabetic, I should say. And walking after meals can help that postprandial glucose be flatter. And then avoiding sweetened beverages, and I probably should have written here avoiding artificial sweeteners as well. So thank you so much. I know that was a lot of information. Thank you for your patience and interest.
I have a question. Oh, this works great. That was a wonderful talk, Dr. Pujari. My question is about Noom and those apps essentially that people can use to kind of help motivate them or guide them for changes. And I'm kind of curious about, I know there's been research published on Noom, finding it helpful. I'm kind of curious about your thoughts of that versus whether it might be more beneficial and how you select patients who might benefit from a Noom versus working with an integrative medicine specialist versus meeting with a primary care doctor, recognizing also it can just get hard to see your primary care doctor on a regular basis.
It's hard, especially right now, right? Actually, I'm a believer in all of it because, like I said, more is better. Noom definitely has data on it that it helps. So that's why I said apps, and it can be very helpful for patients. And I would say all of it. To have having the primary care provider, whoever the provider is, many providers say, oh, it'd be great for you to follow, whatever, to work on this. Even a simple thing like that. It'd be great for you to work on this. Here's an app. Here's some people you could talk to. Maybe getting a coach. With Noom, you can also pay for some actual person coaching. What I find is it depends on the person. Some people are more technology focused. Some people are more people. And so you also got to gauge your patient. But I would say all of it, because behavioral change is really hard. We all know that. I mean, I know that even as a person. It takes time, it takes help, and we all need each other to be able to do what we already know we want to do, but we need help doing it. So I would say the more people, the better. That's how I would answer. Yeah. Thank you, Dr. Dave.
I think there's a lot of great comments about how much people appreciate your focus on lifestyle and how sometimes the patients who are least that we think might be least likely to talk about diet are actually really open to that conversation. And a question about whether you guest lecture for local universities.
I would.
Yeah, I think if you reach out to Dr. Pujari.
Let me tell you something. I went into this. I mean, I was a primary care physician, and I got, honestly, I'll be very frank. I wanted to do something where I felt like I helped patients empower to really change their life, and really change the way medicine's practiced. That's why I do this. I'm actually really passionate about it, and I took risks to do what I do. What I do is unusual right now. I'm hoping that it gets to be more the norm, honestly, because I really believe in it. And what I'm saying, I feel personally strongly about, because I just think it's honestly the right thing to do for patients and for ourselves, really, and for our population. So I say the more it gets out, the better. That's how I feel. So if you have an opportunity for me to talk to other people, I will totally do it.
And I think another question I have is just related to sleep and weight loss. And so I think we all hopefully do a better job now than we did in the past on screening for things like sleep apnea. But I'm also just kind of curious when you see patients who are, um, per se doing everything or claiming that they're doing everything right in terms of caloric intake and exercise, when do you start screening for sleep issues and maybe send someone to a sleep specialist?
Sleep is huge. So their studies, they do these continuous glucose monitor studies. They're starting to do these. I mean, they're very early in research, but now you can start to see some of these things on continuous glucose monitor. And sleep definitely influences blood sugar for sure. And we know with sleep apnea all the different risks that it's associated with. So I have a very low threshold for actually screening for sleep issues. I actually, in integrative medicine, there's key foundational things that we always talk about. So nutrition's one, exercise is one, sleep is another. And then we also talk about rest. So physiologic rest. We distinguish rest and sleep. So rest means, many of us, and especially in the US, we're running all day. And then we sleep, right? But actually there's this concept of rest where you get into parasympathetic mode and you actually relax your system. And that's distinguished from sleep because we actually need both. And so rest is in things like meditation and so on. And by the way, I see a question of how to invite me to speak. You can email me and I'll put it in the message. So just hold on one moment after the talk and I'll put it in the message.
Yeah, and the Noom is spelled Noom and is a prescription, not prescription, but a subscription that individuals can subscribe to. A question from Dr. Lam about regarding coaching and prevention programs. Do you have resources that you refer to? I know of the YMCA Diabetes Prevention Program for pre-diabetic patients, but just wondering about other resources.
Honestly, nowadays there's a lot of coaches. You can just, honestly, patients can just look for health coach on the internet. And the most important thing in a coach is you want to click with the person. And they have to have had some training, have to have training. But a lot of, like, for example, the gyms in the area, they'll offer health coaching. YMCA is a great option, but actually I often just look at the internet and see like who are the health coaches that are available, because some of it's just honestly the accountability of having to go talk to somebody every week about what you're doing, because often we know what we're, and so having somebody say, well, did you really want to make that choice? And they're like, well, no. And it helps us to change. So often I just look on the internet for health coaches. Thank you. Oh, there it is. Thank you for the email. That's my email.
Well, great, Dr. Pachari. Thank you so much. And I'm sure if people have other questions, feel free to reach out to Dr. Pachari in our email.
You can absolutely email me. So I welcome that. So thank you so much. Bye.
Thank you.